From the American Academy of Pediatrics.
Keeping kids healthy requires so many layers of anticipatory guidance.
A wide-ranging report from the AAP touches on all the ways we can counsel families.
What we really are talking about are those pillars that really make a difference for health overall. Nutrition, physical activity, sleep, media use, and also just emotional well-being.
Plus, a pediatric perspective from our journal offers language we can use when talking to teens about opioids.
It gives good guidance for how pediatricians can have this nuanced conversation about how teens can keep themselves safe if they are using drugs.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a conversation about the many ways we can help promote a healthy, active lifestyle for our patients.
You know, Joanna, recently I feel like we've seen a real shift in focus from addressing health care issues to supporting overall health. It makes this podcast hard to do because how do you distill children's overall health into 20 minutes of content?
I know what you mean. We certainly learn a lot about specific diseases and interventions, but they're all connected to fundamental aspects of how we live.
The AAP recently released a wide-ranging clinical report, The Role of the Pediatrician in the Promotion of Healthy, Active Living. This may be the sort of thing the word omnibus is meant to describe.
I'm reeling a little from the sheer breadth of this report. Is there someone who can break it down for us?
Well, that's a challenge, Joanna, but let's tackle it with one of the co-authors, Dr. Chris Bolling, a retired pediatrician in Cincinnati, a volunteer professor of pediatrics at the University of Cincinnati College of Medicine, and an active member of both the Ohio and Kentucky chapters of the AAP. Chris, welcome.
Thanks a lot, David. Joanna, it's great to be here.
We're excited to have you. And I just have to say that the title, Active Healthy Living, may be the most ambitious we've ever covered. What is included in an active, healthy lifestyle for kids?
You know, it's a lot of things, Joanna. This report actually came out. We started off trying to update our old obesity prevention statement. And as we went through it, we really decided that it's really more about health promotion than it is obesity prevention. And this is really things that are important for all kids, regardless of their body type, body size, anything. There are really things that we know that make a difference, and those things don't get a lot of press. So we felt it was a real opportunity to talk about those things that we know that make a difference for all kids, not only in preventing obesity, but promoting health. You know, and there are things that we know. I love that you guys describe this as an omnibus sort of article or sort of statement, because what we really are talking about are those pillars that really make a difference for health overall. Nutrition, physical activity, sleep, media use, and also just emotional well-being.
So this clinical report was a follow-up to another report on obesity prevention, but you chose not to put anything about obesity in the title. What made you make that decision to have this more all-encompassing active, healthy living title?
You know, Joanna, we got a lot of really good feedback from our colleagues in the eating disorder world. And we really came away with this saying, this is really about developing a healthy relationship with food. We don't get anywhere with obesity or with eating disorders by not saying anything, by just ignoring things. So the goal here is promotion of healthy eating habits that will prevent eating disorders and obesity. We just want people to have a healthy relationship with food, and we think that that's good for everyone.
So I've heard of the biopsychosocial model of health, but this report talks about something a little different, a socio-ecological model. What's the difference between those ideas?
You know, I think they're pretty equivalent, David. I think they really wind up talking a lot about how we need to be thinking about chronic diseases and wellness really in terms of what we do individually, what we do in our family, what we do in our schools and our workplaces, what we do in our communities, what we do in our city, our state, and our nation. All those, as you've seen in the biopsychosocial model and in the socioecological model, really, those nesting circles where there are these various things, places that we can intervene to promote good health.
And we want to get into some of those pillars of health that you mentioned, Chris, but I know in our hospital we screen for social determinants of health, and this report puts them front and center. Can you talk about their importance when framing what an active, healthy lifestyle is?
So with healthy, active lifestyles, social determinants of health really need to be front and center because we're talking about things that are really profoundly affected by social determinants of health. Your nutrition status, your food security, your ability to be physically active in a safe community, your ability to have good parenting. So those things that impact those social determinants of health, those social modifiers of health, are really critical when it comes to healthy, active living. It's why we see things like obesity, things like, all the other illnesses that we associate, oral health, just about everything is influenced by social determinants. And these really profoundly affect our under-resourced communities. Those social determinants can both help and hinder, and we really need to address those if we're going to be successful in effective health promotion.
I understand why obesity isn't part of the report's title, but it is something you address. I probably know you best from your work on healthy childhood weight. How can we talk about obesity in ways that avoid stigma and also improve outcomes?
Weight stigma and weight bias have really been a problem over the years, and I think that we are beginning to make some progress with it. The first step is always recognition. I could tell you so many times early on when I was working in obesity how many really, quite honestly, stupid things I said to families and ways that I positioned things that made kids feel terrible. The blame game doesn't work at all. So I think the first thing that we really need to do, and I think providers are getting much better at it, is really calling attention to weight bias. We addressed it a lot in the clinical practice guideline on the assessment and treatment of pediatric obesity from last year's clinical practice guideline. And we wanted to really hit it again this year in this healthy active living text as well. I think there are ways that we can empower providers to not only be aware of it, but then also to do things in their office to cue kids and cue families in that we are not in the blame game, that we are acknowledging that weight status is something that is determined by a whole host of factors, not the least of which are just plain genetics and things that are really beyond families' control.
And this report talks not only about what kids eat, but also how they eat. What's that relationship?
Well, like all aspects of parenting, it's really about hitting the sweet spot of sort of what we talk about. You don't want to be authoritarian or too permissive, but you do want to guide kids. You do want to be somewhat authoritative in the whole process, meaning that when we're feeding kids, much like we do with other parenting issues, you give kids options and let them choose among options. Not necessarily, we're not believers in the clean plate club or just eat whatever you want, but here's what your choices are. And kids actually feel the consequences of those choices. If kids choose not to eat, the kitchen doesn't stay open indefinitely. The kitchen still closes. And kids might need to feel a little bit hungry before the next time that mealtime comes around. So kids really, we give them leeway and we give them choices. And we do responsive parenting, meaning that we try to use food as a cure for hunger, not as food for some other reason. Food as a reward or a punishment. That food really needs to be about nutrition and that kids eat when they're hungry and they're able to turn away and say, I'm not hungry, but knowing that they'll have to face the consequences of that if they choose not to eat.
We could talk a lot more about eating, nutrition, and obesity, but we also want to touch on some other aspects of the report. Podcasting itself, like what we're doing now, is pretty sedentary. But again, your report is very active and engaging. And then there's this whole section on physical activity. How can pediatricians get their patients moving?
That is a great question, Joanna, and I have to hand it to the lead author on this. I was one of the authors with her, but really, Natalie Muth in San Diego, who is the first author on this paper, is just absolutely spectacular in that area. How we do things as a family. She has a book out called The Family Fit Plan that talks about things, strategies for making your family more active. Things that like building in activity to your daily routine, doing things as a family, not punishing one child in the family by making them be more active than everybody else, but just making it part of a daily routine that's fun, that's interactive. So there are a lot of positive things that come out of physical activity. And we really wanted to hit that in this document. Saying that physical activity needs to be a bulwark of family time. It reduces our screen time, it increases our mobility, it increases your muscle mass, so you burn calories more regularly. It's just so important in so many different ways.
It's hard to overstate the importance of pediatricians in this, but parents are naturally the major drivers of a lot of these behaviors. Are there some ways that we can help parents be more successful in encouraging healthy habits for their kids?
David, I'm also a big believer in motivational interviewing in practice. So some of the principles that we as pediatricians employ that are MI-based sort of skills, I think are really important in that zone, particularly when it comes to physical activity. Physical activity can come in so many different varieties. It can come in small snippets. It can come in big chunks. It can be individual. It can be team. So I think what our job is as pediatricians is not to be prescriptive, but to talk with families about what kinds of activities are sustainable and fun and effective for them. And the best exercise plan, as we all know, is the one that you can stick with. So really listening to families and figuring out what is best for them. Everything needs to be tailored, but I think that physical activity piece especially needs to be tailored because not everybody likes the same thing when it comes to physical activity.
Well, if there's a yin to the yang of activity, perhaps that's sleep. So how do we ensure kids get enough sleep, and how do we help with that as they grow?
Wow, Joanna, I just think that, sleep, we keep coming back to it in so many different illnesses. Sleep is just critical when it comes to wellness. We really tried to lay out what we know about sleep in this document to give parents a target. Again, it is a team effort when it comes to a family. When we see sleep start to break down, we see the other domains really start to break down as well. We really see physical activity take a hit. We know that a lot of things happen with metabolism and hunger when sleep is interrupted. We just know that the family function starts breaking down. We certainly acknowledge the importance of sleep. I think it's important to give parents targets, give them ideas on what sleep numbers really should be, what sleep duration should look like. And then I think really helping families problem solve where sleep is breaking down. I think as a pediatrician, when you start asking about sleep, then you start finding out that the kids are staying on their phone all night or waking up in the middle of the night to answer texts, or their eating patterns are very unusual where they're eating very late at night and not sleeping. There's all sorts of things that we start finding out when we start asking about sleep.
Chris, I'm so glad that you mentioned kids being on phones or devices all night. Looking more globally, how do we work around these ubiquitous screens when we're trying to encourage healthy habits for kids?
David, I was really glad to be doing this podcast with you because, I know that you were very involved in that media use statement that came out a few years ago. We used to talk sort of rudimentarily about screen time if you remember the old 5-2-1-0 mnemonic, which was, eat 5 fruits and vegetables per day, get less than 2 hours of screen time per day, 1 hour of physical activity, and 0 calories from sweet drinks. I think we've become more savvy about that, knowing that 2 hours is not just some magic number, that we need to talk about screen time more globally. We need to talk about it as a family, and families need to make decisions that work for them, looking at both the educational content, amount, and when that screen time occurs and how that screen time is used.
And because we're talking about screens, we also know that these have an effect on children's mental health. How do we promote social, emotional wellness for kids of different ages?
I think your comment about it being different for different ages is really important. I think that there's also a lot of, we mentioned it earlier about parenting skills and responding appropriately when kids are hungry and not using food in sort of unusual ways. We do have a table that addresses this based on age, and it's very different based on age. But, social emotional well-being has a lot to do with what kids' needs have. I always go back, I think we all flop back into our Psychology 101 class and our Ericksonian stages. It's a little different as you go along. With young kids, it's more about trust and about security. As kids get older, it's about developing those positive relationships with peers. It's about learning and promoting independence. It's about learning and really developing in the progression to adulthood. It's interesting when we talk about, to go back to the motivational interviewing piece of it, I always start talking with providers, like they'll say, like, when do you do the motivational interviewing? When do you do the behavior change work with the child? When do you do it with the family? And I think a lot of there's a corollary with this social emotional well-being piece. Under age 6, most decisions are kind of made by parents. After age 12, I think just about decision is made by the child. And between 6 and 12, it's a bit of a hybrid. So I think that the social emotional well-being bit of that also fits in with that decision-making stuff. We're sort of slowly promoting this independent thought and this progression that really fits together with the development that we talk about with families.
Well, I have to say, Chris, this conversation has been almost as wide-ranging as the report itself. Before our listeners go read this, can you leave them with one last takeaway?
So Natalie and Tammy and I, when we wrote this, we were really saying, when we saw the final piece of it, we said, what this really does is this gives pediatricians, hopefully, the courage to act on those things that we know are important. We want to tell pediatricians and parents these things are worth it. Fighting for good sleep, fighting for emotional well-being, good nutrition, good physical activity, those things are really important. And we should be spending time on those things, that the health promotion, the benefit of those things is worth it. And so I guess the take-home message in my mind is, maybe it's not rocket science, but it's still really an important piece of being a pediatrician. These pillars, these important areas are important for a reason. They really do promote wellness and they prevent illness.
And we want to promote people going to read your paper because it's pretty comprehensive and very useful. And Dr. Chris Bolling, thank you so much for talking with us today. My pleasure. Thanks for inviting me. To read the clinical report, The Role of the Pediatrician in the Promotion of Healthy, Active Living, go to aap.org/podcast.
Coming up, we'll look at ways we can talk to teens about keeping themselves safe from drug overdoses.
We have covered opioid overdoses on the show before, talking both about babies with neonatal opioid withdrawal syndrome and adolescent incidences of overdose. But despite our efforts to educate on this topic, the problem seems to be getting worse.
That can be so discouraging, but I think we're still in the process of figuring out the best evidence-based ways to improve our outcomes, and our communication with our patients is really key.
One of the best communicators about preventing opioid overdoses is Dr. Scott Hadland. He's joining us on the show today. He is a triple threat with board certifications in adolescent medicine, addiction medicine, and pediatrics. He is also the chief of adolescent and young adult medicine at Mass General Hospital for Children and an associate professor at Harvard Medical School.
Last time we spoke was on episode 165 with Erie Solomon, who told us their experiences with substance use and how they became an advocate. Today, Scott's back with a pediatric perspective, anticipatory guidance to prevent adolescent overdoses. Scott, welcome back.
Thanks for having me.
So, the last time you came on the show, Erie joined you, and when you wrote this paper, you were also joined by other advocates trying to reduce fentanyl overdose deaths in teenagers. Who were your partners on this?
We wrote first and foremost with a woman named Deb Schmill, who is somebody I've come to know here in Massachusetts as somebody who has worked hard advocating to raise awareness about fentanyl and the risks of overdose for young people. Deb lost her young daughter, Becca, far too tragically and far too early in her life from a fentanyl overdose, from a pill that she believed to contain a real medication, but actually contained fentanyl. It was a counterfeit pill. And this is a problem that we see replicated all across the country right now. And it's really causing an unprecedented number of deaths in adolescents.
So what is driving these overdoses, particularly in adolescents?
Fentanyl is really the top cause of overdose deaths in young people. It accounts for at least about 8 or 9 out of every 10 drug overdose deaths in the United States among teenagers. And just to put this in perspective, overdoses now kill the equivalent of a high school classroom of teenagers every week across this country. Overdoses are now the third leading cause of death in children under the age of 19 following firearms and motor vehicle crashes. And so this is a truly urgent scenario. And the data tell us that this problem is getting worse, not better.
How can discussing opioids fit into the anticipatory guidance pediatricians already give our adolescent patients?
Well, the case that Deb and I make, along with Sarah Bagley, another expert in the field of adolescent addiction medicine here in the country, and who has really sort of led a lot of the thinking about overdose prevention across this country, we really make the case that just as pediatricians are increasingly comfortable talking about firearms and have, for many years been comfortable talking about preventing motor vehicle crashes by asking people to wear seatbelts, so too should we now be talking about overdoses routinely as part of our general practice with teenagers and providing anticipatory guidance around it.
I'm scared by the rising number of overdoses and even deaths, and I see all the literature on this. Do we, as pediatricians, need to put fear into the hearts of teenagers everywhere to help prevent this?
I think what's really critical when we talk to teens about drugs is to be very realistic and present the facts as they are, and not to be hyperbolic, not to be bombastic. So, for example, teens that I care for, and I work in a pediatric addiction clinic, teens will sometimes tell me, I heard that, somebody told me that cannabis can kill me, or somebody told me that if I vape, horrible things will happen to me. And certainly there are harms from these substances. And I think what's really important for us to do, though, is to have a realistic conversation in which we're very realistic about the harms of these things. And, quite frankly, cannabis has a lot of harms for young people, but it most likely is not going to result in the death of a young person. I think it's really important that we have these realistic conversations, because when we need a young person to believe us when we say that fentanyl could potentially kill you if you have a pill and you have no tolerance to opioids and it has a particularly high concentration of fentanyl in that pill, we need young people to believe us in that moment.
Let's talk about how to even start. What should pediatricians be saying to adolescents when they're worried about overdose?
I think the first thing you want to do is invite the teenager into a conversation. Ask them if you can talk about it. And I think most teens are open and willing to have this conversation. I then spend a little bit of time trying to understand what have they seen, what have they used themselves. And sometimes it's easier to ask a teen about their peers and what they see going on in their social circles rather than asking about their own behavior. And then you can sort of use that as an entree to the things that they may have done. And I think it's really important to start with the recommendation that as your doctor, it's really important that I tell you you shouldn't use substances to protect your health, safety, and well-being. And yet, as your doctor, I'm also here to have a conversation with you about safety, because safety is so important to me that I really want to focus all of our efforts on that if you are using substances. And I spend time talking to teens about how they can keep themselves safe if they are using, say, counterfeit pills or pills that they believe to be real pills that might be contaminated with fentanyl. I tell them, of course, we want you to avoid using substances. If you do use substances, make sure that you use with somebody else so that somebody else is available to call 911 if there's an emergency. Make sure you understand what are the signs of an overdose. Somebody who's overdosing will have decreased breathing. They might appear sleepy. They might actually, lose consciousness, and they might start to turn blue or pale. And recognizing those signs and then delivering naloxone is the thing to do to save a life, and then to call 911 so that person can get definitive medical attention. There's other recommendations that we put in the piece, like suggesting to teens that if they are going to use a pill, don't use it all at once. Start with a small amount, break it into half, break it into quarters, and see how you feel after trying that little bit to assess its potency. And then avoid mixing it with other substances that can be sedating, like alcohol or benzodiazepines, because some people will use multiple things at the same time, and that can increase the risk of overdose.
You mentioned naloxone. Now, I know it's over the counter, but do you write a prescription for naloxone for all families when they come to see you?
I think this is a really critical point. Naloxone is a life-saving medication that, when sprayed up the nose, can reverse an opioid overdose within minutes and is truly life-saving. And so I think it's really important that young people know what naloxone is, know where they can get it if they want it. And in fact, I actually recommend to many of the families that I work with that they consider having it in their homes. In our house, we keep it in the junk drawer in a central location, just like we keep a fire extinguisher in a relatively central location in our home. I carry naloxone around with me in my backpack so that I can respond to an overdose. And I think that many teens and families might want to take this same approach. What I usually do to get naloxone into the hands of the families that I work with is either give it to them in my clinic, because we have a supply that's available. If a family wants to have it prescribed, we can absolutely do that too. The advantage to having it prescribed is that insurance typically covers it with no copay or with a very small copay. Or another option is for teens and families to buy it over the counter at a pharmacy. And that's a great option for many people. Unfortunately, the cost is a little bit high. It's $45 for a pack of 2 nasal sprays. And so for many teenagers, even though they can walk into a pharmacy and buy it over the counter, they're legally allowed to, that will be a pretty prohibitive cost for many.
Oh, it's so nice to hear all the options that you give families. And, when a teenager does disclose that they've used street drugs or bought pills on social media, do you have to tell their parents? How do you navigate confidentiality in these situations?
That's a really tricky situation. The classic teaching has been, when we do that confidentiality statement, we tell the young person that the things that they tell us are confidential, that we're not going to share that information with their parents unless we have a safety concern. And this starts to become a safety concern because we know teens are dying from fentanyl overdoses at an unprecedented rate. The way that I usually approach this is I initiate a conversation with the young person to tell them all the reasons that I think it would be helpful for us to share this information with their parents, and see if I can get their permission to share it with their parents, so that I don't have to be in the position of breaking confidentiality, which, could be life-saving, could be critical, and yet could also destroy my relationship with the young person if they had told me that information in confidence.
Scott, I have to thank you so much, because this conversation has really made me more confident in having these conversations on opioid use and overdose prevention with adolescents and their families. Do you have any last takeaways for us on these discussions?
Right. I think it's really important for teens to still hear from us, even though we want to keep them safe when they use substances. And that's what this pediatric perspective piece that we wrote is all about. It gives good guidance for how pediatricians can have this nuanced conversation about how teens can keep themselves safe if they are using drugs. Yet at the same time, I actually think it's really important for teens to still hear the recommendation from us that the safest way to keep yourself alive amid this crisis is to not use substances at all. That, drugs in the year 2024 can potentially be contaminated with fentanyl. And because of that, the safest thing to do is to not use it all. But if you are going to use, here are the ways that we recommend that you keep yourself safe. And I recognize this is not a super comfortable conversation for many pediatricians. So I'd really recommend that people take a look at the perspective, because we put a really nice table in there and some sample language that pediatricians can use that we believe if you bring that to your patients, you can have really good conversations with them that could save a life.
Yeah, I want to recommend that everybody read it too, because it really is thought-provoking and I think super helpful. And Dr. Scott Hadland, it's been such a pleasure to have you on today.
Oh, back at you. Thanks for having me.
To read the article, Anticipatory Guidance to Prevent Adolescent Overdoses, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
My Say Ah is going to be Say Osprey. Here in coastal North Carolina, we have these amazing Seahawks that are kind of black and white, and they're just the most spectacular birds of prey. And this seems to be a really good season for them. We've had 3 of them wheeling over the neighborhood, and we've gotten to watch them dive and hunt and then perch in a tree and eat the fish. And I don't know, I just kind of love that. So I feel very privileged to get to witness this.
I love your bird watching Say Ahs. They're some of my favorites. My Say Ah is kind of like a Say Ah. I just went back to work after being off from maternity leave. And that's not positive or enlightening for me. But what is that my coworkers have been absolutely amazing. Checking in on me, flowers, candy, things I couldn't even imagine. And you don't really remember the time when you go back to work. So I know my coworkers are amazing. They probably did it for my other kids too, but I'm really struck with how thoughtful and giving they've been.
Oh, that doesn't surprise me, but that is so lovely. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about a new resource for helping parents navigate social media.
We'll speak with Drs. Jenny Radesky and Megan Moreno. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.